Thanks for this kind introduction. I think unlike other speakers, I've been given 2 diseases to talk about. So Eva, I'm not going to take 40 minutes, so I'll try to stick to my time. So I think my task today is to see whether is this 2 diseases or 1 diseases, or does it really matter? Do you need to separate it down into 1 disease or 2 diseases is the question. I've added the pathogenesis to the middle of that as well to see what on top of the diagnosis and therapy of these diseases as well. So just to give a background, I'll probably start off with a clinical case. This is a real-life patient I saw about 2 years back. So she's a 32-year-old British Airways cabin crew member. So she presents with significant tiredness. She is markedly out of breath. She does have non-traumatic bruises as well, and she gets recurrent mouth ulcers, which has been going on for 6 months. There is no drug history or significant past medical history. Notably, all her 4 grandparents have got malignancies around the age of 60s to 70s. So just that's to park on one side. So when examining her, she's short-statured. She's about 5'5". Apologies for people who are short. So she is short-statured. She's ecchymotic, and she does have mouth ulcers. There is no warts or hypopigmented lesions on there, and system examination was quite unremarkable. So when we do her blood indices, she is pancytopenic, obviously, with a neutrophil count of 0.9, anemic, and also thrombocytopenic with platelets of 19 into 10 to the power of 9. But she's not needing any blood transfusions as of yet, and the reticulocyte count is inappropriately high for that degree of anemia, although within the normal limits. Did a bone marrow on her. The trophine was variably cellular between 0 to 40% cellularity, so i.e. patchy cellular in certain areas, normocellular in certain areas as well, with no fibrosis. And the aspirate was hypocellular. She did have megaloblastic erythropoiesis, and there were some micromegakaryocytes, but around 10% limit with an increased erythroid ratio, ME ratio, or reversed ME ratio of 1:3. Karyotype revealed that she does have trisomy 8 in a few metaphases, and the ASXL1 is mutated at a very low variant allele burden, or a clone size of 8%. So her LDH is about a couple of times upper limit of normal. She is found to be low B12 and low ferritin levels as well. And the PNH clone reveals that she does have a moderate clone. And as I said, she's transfusion independent. So this is a real-life patient, 32, short stature, with a family history of malignancy, pancytopenia, but not transfusion dependent, with marrow, which is variably cellular, trisomy 8 clone, ASXL1 clone, and a moderate PNH clone. So the question is this aplastic anemia? Is this myelodysplastic syndrome? What's the PNH has got a role in this? What is that linking it? And is this an overlap disorder? Is there an entity called overlap? Because we, at least in this meeting, we know that there is a significant MDS, MPN overlap diseases. So is there an overlap disease between aplastic anemia and MDS? And what are the other pertinent question which is coming up in the recent discussions is there a constitutional bone marrow failure to this patient's presentation with cytopenia? Is there an inherited bone marrow failure gene that you need to look out for in this category? And what other further tests will do? So with that background, I'll try to take you through what we know in the context of MDS. So we know that pancytopenia is something which is, obviously you can say, pain in the backside when patients come. When you can't ideally diagnose, do they belong to one of these bone marrow failure categories, or is this an immune mediator, or is it drug related? And to make more confusion, we've got this category of idiopathic cytopenia of unknown significance as well. So what I'll go through in my talk is, are hypoplastic MDS and aplastic anemia, are they mutually exclusive, or are they distinct disorders? Can you have a diagnostic criteria? What is the pathophysiology defining these 2 diseases, and the cytogenetic genetic profile and therapy and prognosis? Before that, I think for diagnostic purposes, we need to define, is there an entity called hypocellular MDS and how different is that to normocellular or hypercellular myelodysplastic syndrome? Is it really a different clinical pathological biological entity? And we know that in about 10 to 15% of patients, we do see hypoplastic bone marrows in the context of myelodysplastic syndrome. And this is just a snapshot of around 150 patients, which we've seen in King's College Hospital. It's unpublished data indicating that there are differences between these two cohorts of patients, i.e. comparing between hypoplastic MDS and also normocellular or hypercellular MDS. There is difference in the median overall survival. Not only that, the age is different. There is increased cytopenia and transfusion dependency, and this incidence of autoimmune diseases are significantly higher compared to the normocellular cohort, and the rate of progression to acute myeloid leukemia is also low. If you look at this data, which was published last year, the mutational profile is also different, as well as the prognostic significance, with median overall survival significantly different between these two entities, and the cumulative incidence of leukemia being significantly different. So if we parked that to one side, and we are sort of clear that there is definitely an entity called hypoplastic MDS from normocellular or hypercellular MDS, then how would you differentiate that with aplastic anemia? And is this being defined? Is there a diagnostic definitive category? Is it being defined in WHO, or has it been defined elsewhere? So the one thing to look for when you differentiate between hypoplastic MDS and aplastic anemia is you have to rule out other conditions like hypocellular AML, and also infiltrative conditions, and also fibrotic conditions. So what data do we have for this diagnostic category? So the only data which is published for hypoplastic MDS as a diagnostic category was back in 2009, and that's only looking at a group of 60-odd patients with 3 FAB workshops over a period of 2 years. And quite rightly, morphologically, they were defined as indicated here, with absence of ring sideroblasts in the context of aplastic anemia, or having 2 or more abnormal localization of immature precursors in the context of MDS, and also presence of this 10% dysplastic lineage. But we all know that in the context of empty bone marrow, how difficult it is to do a 500 cell or a 500 cell differential in the peripheral blood and bone marrow respectively. Immunohistochemistry does help mainly to look at the megakaryocyte morphology and also the reticulin fibrosis. The things which are evolving are obviously the metaphase cytogenetics, the SNP karyotyping, which could help to differentiate between presence of an abnormal clone, but it doesn't help to see whether the abnormal clone is part of an aplastic or the hypoplastic MDS. And I'll talk about the DNA diagnostics in the context. How is this helpful to identify patients with hypoplastic MDS versus aplastic anemia? And we all know that in hypoplastic MDS, if there in the context of a hypocellular marrow, if there is an increased reticulin or abnormal CD61, which is megakaryocytes, or increase in CD34 clusters, we know that that could go in the context of hypoplastic MDS. But if you have a PNH clone in the presence of either of these bone marrow failures, you could totally disrupt the cellularity in the marrow, with significant erythroid dominant hemopoiesis seen when you have a bone marrow failure, either AA or MDS, with a large PNH clone, as seen in our patient. The cellularity could be significantly variable between patients who have a PNH clone versus those who do not have a PNH clone. That's due to ineffective erythropoiesis and also hemopoiesis as well. So this is some of the distinctions you can make, because as you know, dyserythropoiesis doesn't mean dysplasia, because it's very commonly seen in aplastic anemia, more so if you have a PNH clone, and more so if they have a associated B12 or folate deficiency, while the rest of the ones I've gone through in the earlier slides as well. But we know that aplastic anemia, for all trials and purposes, is a pure immune-mediated disease, where the target organ is the bone marrow stem cells. The stem cells are the primary insult of the attack of this immune disease, similar to multiple sclerosis and rheumatoid arthritis, where the target organ is defined. Here we know that the bone marrow stem cells are the target organ in the context of aplastic anemia. But you could have significant immune dysregulation in MDS as well, because this has been historically reported as well, that clinical observations of significant coexisting autoimmune diseases, paraproteins, low-level autoimmune problems. And this was also shown when we did a large series between King's and the Moffitt group in about 800, 900 odd patients, that 30% of patients did have an underlying autoimmune disease, and that reduced the risk of progression to acute myeloid leukemia. So here you have two diseases. Both could be associated with immune dysfunction or immune dysregulation. So does that really help you to differentiate between these two diseases? We've looked at the morphological diagnostic criteria. Some of them help us to differentiate. We've looked at the immune profile, but does this really help to differentiate between these two diseases? And the third thing which I'll talk about is clonal hemopoiesis. We sort of talk about clonal hemopoiesis as a very, very loose term, but I think we need to be extremely careful when we use the word clonal hemopoiesis in the context of diseases which has got immune-mediated backdrop, because you could have significant T-cell clones in the context of autoimmune diseases and bone marrow failures. They could be oligoclonal or monoclonal T-cells or TLGLs. Or you could have immune escape clones, which is classically described in the context of PNH and the other cytogenetic abnormalities described. I'll talk about this good and bad clones, what do they mean? And this concept about age-related hemopoiesis and what is aging related to the clonal hemopoiesis versus disease clone. And the concept in aplastic anemia is what is true clone versus what is pseudo clone. Because if you have an empty bone marrow, if you have a couple of stem cells in there which are causing this clonality, does it really mean true clonality or is it pseudo clonality? And I think the favorite is the clonal flux. How does the flux happen? Is it a transient phenomenon? Is it a fluctuant phenomenon? And how do we eradicate? Because that's when the therapy comes into the concept of it. Just to give you a backdrop, because we know that this is elegant work done by Elaine Slern showing that trisomy 8 is a significantly immune escape clones due to upregulation of WT1 and other pro-survival signals on the surface of the trisomy 8 cells, which leads to expansion of the trisomy 8 clone. Similar in the context of 6p UPD as well, because that's the locus of HLA-A locus, that you do have mutation or loss of heterozygosity of the A locus, which leads to expansion of these clones, which is predominantly seen in the Japanese group. And also recently described 13q in the context of, which was usually described in the context of MDS unclassified, but that's more seen in the context of aplastic anemia. And incidentally, the PNH clone is part of the 13q cytogenetic clone as well. And when you look at the other clone, the monosomy 7 clone, that can have significantly diverse origins, because you could have monosomy 7 clone happening in different contexts in different diseases. We know that in MDS AML that's significant. We know that in the context of GATA2 and familial monosomy 7 that's seen as well. Post-transplant, predominantly after cord transplant, that's seen. And also after growth factors. We've been historically known about the Cosman syndrome, truncated GCSF receptor, and the increased monosomy 7, but also in the context of TPO-mimetic like L-thrombopag as well. And in aplastic anemia, it's quite different, because if you go to NIH, if you do have a monosomy 7 at the context of a presentation with aplastic anemia, they would not treat it along aplastic anemia lines. But we have seen a significant proportion of patients whose monosomy 7 goes, patient loses the monosomy 7 clone after the ATG treatment. But if it is persistent, then that means it means progression to AML and MDS. And that could be due to various reasons. It could be due to the stress, proliferation, telomere loss, or to the genomic instability as well. But the concept is that why should aplastic anemia, which I described as a pure autoimmune disease, sit along with diseases of clonal hemopoiesis? You could look at any diseases surrounding aplastic anemia, and that is associated with some degree of clonality. Not only that, with increasing recognition that we are identifying a number of patients who have inherited bone marrow failures, that the number of group of these patients are increasing exponentially. Even just last year, we'd seen 4 cases of GATA2 related aplastic anemia and MDS referred. So this is increasing, that even in the patients over the age of 40, 50, or 60, you have to be careful and try to identify patients who do have inherited bone marrow failure. And that led on to look at the mutational profile, and not surprisingly in the context of aplastic aplastic anemia, we find that about 20% of patients do have mutations either of DNMT3A, ASXL, BCOR with a low mutation allele burden. So the concept is that it could be that over the course of disease that you could have too few stem cells in the context of aplastic anemia. You give immunosuppressive therapy, the stem cells could recover, and you could have a normal hemopoiesis. But what could happen more commonly is that you do struggle to recover your stem cell pool. You could acquire a dysplastic stem cell, you could acquire mutations, and you could go into a full-blown MDS as well. So that's what we think happens in the context of AA, that these mutations expand out. So I think I'll skip that, which essentially describes the same process of stem cell attrition due to proliferation in the context of aplastic anemia and the proliferative pressure due to both the treatment and the disease, leading on to clonal hemopoiesis, leading on to emergence of abnormal clone, which could be good or bad. Bad indicates that you're going into malignant progression as well. And but what we don't talk about significantly is the underlying immune surveillance and the genomic instability seen in this group of patients as well, what that determines it. But we know about the association between clonal hemopoiesis and inflammatory diseases, because this is not just a association alone, because we know that now it's described that if you're over the age of 60, or at least around 5% chance that you will have these mutations that keeps on increasing. But the mutation doesn't mean that you have an increased risk of mortality due to the MDS AML, but because of other inflammatory conditions. And I think for want of time, I'll skip the next slide, but anyone interested, this is a fascinating data in Science, which was published 2 weeks back, looking at a TET2 mouse model and how the TET2 mutated cells from the bone marrow go into the cardiovascular plaque and increase the cardiovascular mortality, indicating these TET2 clones, which we think are CHIP bystanders, might not be just bystanders, but they are doing other things as well. So when it comes to treatment in the last 3 to 4 minutes, there are various ways to treat these diseases, both in the context of, if you look at it in a pragmatic way, can you eradicate these clones? Can they go down spontaneously? Can you modulate the immune system, either by immunosuppression or other treatments? Or can you rejuvenate the stem cells? Can you use Dansrol in the context of telomeropathy, or L-Trombopag, which we like to call it as a stem cell cookie, to see whether you can rejuvenate the stem cells in this context. But before confusing you, I'll want to go to the basis of how you treat aplastic anemia, and obviously it depends on the age of the patient. If you're less than 40, no identical sibling donor. If you do have a donor, transplant. If no, you go for ATG. Same for above 50, you go directly for ATG. For patients who fail that treatment, you go in for an unrelated donor transplant. In the middle, you can go both ways depending upon the fitness of the patient. And in children, there is some data upcoming to showing the role of unrelated donor upfront transplant as well. But you could have clones which are eradicated. This is in the context of PNH, which is also an immune-mediated disease, that these clones could be eradicated spontaneously. This is a patient monitored over a period of 10 years, loses the PNH clone spontaneously. But the PNH clone goes, but the normal hemopoiesis is not normal. It's contributed by other mutated clones as well. And the same thing with transplant. Can you improve the survival? Because that's the sort of therapy which eradicates the clone as well. So can transplant cure these diseases, both AA and MDS in this context? And we know about this data in the context of aplastic anemia. I'll skip over it in want of time, but the p53 mutated clone can respond to azacitidine, but the problem is the durability of response, which was again shown by the WashU group, showing that p53 in the context of decitabine, that all the patients they treated with decitabine with the p53 mutation had a complete cytogenetic and a hematological response with losing the p53 clone over the time period of time. And this was discussed early on in the discussion. So this is clonal hemopoiesis in the context of aplastic anemia over a period of 12 years. So you could see these clones, they can go up and down. They can flux as well with ASXL, SETBP1, and other mutations. So you, as was talked in the discussion earlier on, identifying these clones doesn't mean you act on these. So it is important to know what they mean, because this is a 70-year-old who had a hematological response to ATG and cyclosporin, but had these clonal fluxes around this over a period of 12 years. And you can argue that if you have these in the context of aplastic anemia, at least in people who are less than the age of 60, if you have these DNMT3A, ASXL, and other mutations, if they have unfavorable mutations, would you think of doing an early transplant for these group of patients? Can you eradicate these clones by transplant? And we know with ATG, in aplastic anemia, the response is around 70%, and most of the responses is partial responses. While in the context of MDS, the response is only 30 to 40%, while in the context of aplastic anemia, it is 70%. And the durability of response in MDS is also low as well. But we talked about immunosuppressive therapy, but there are immunomodulatory therapies as well, which I've just summarized here, but could be used in the context of hypoplastic MDS as well. Obviously, L-Trombopag is something which has come up in the last few years as a treatment in the context of refractory aplastic anemia, with about 40% of patients showing response. The response could be due to various reasons, due to the MIPL receptors on the stem cell, or is it having a paracrine effect, or is it having an off-target immunomodulatory agent? And I'll sort of finish with this couple of slides, because this is a data which was published yesterday or day before in the NEJM, i.e. L-Trombopag added to aplastic anemia in the context of ATG and cyclosporin in patients with de novo idiopathic aplastic anemia. And you could see the response is close to 95%, and complete response is close to 60%, while historically complete response was only in the context of 10%. And not only that, this was a disease where the overall survival 40 years back was only 10%. Now the overall survival is close to 90–95%. And not only that, the CD34 stem cells are increased 3 to 5-fold in the bone marrow, indicating that there are treatments which are modulating this. And the same thing with MDS as well. This is a trial published in Lancet Oncology comparing L-Trombopag with placebo, showing that about 50% of patients could have responses in the context of this TPO mimetic. And obviously, Dansrol in the context of telomeropathies has been used. This is again from NIH, showing that high dose of Dansrol can improve the telomere length and also can show hematological responses in this group of patients. So these are two diseases, but there are so many similarities between these two conditions, and sometimes it's important to take note that these two things could coexist both concurrently or can follow metachronously as well. But as a simplistic way, if you look at a pragmatic way of dealing with it as a simple clinician, you can look at it as an etiology of bone marrow failure. Do you think it's immune-mediated? Is this because of all these abnormalities like del13q or PIGA or other TPO levels? Then you treat them with immunomodulation. Do you think it's a pre-leukemic clone due to these mutations or del7q? Still, you can think of treating them immunomodulatory agents, but can you use early transplant investigational agents and hypomethylating agents? But medicine is never simple, because there is a large group in the middle who do not fit into this category or that category. But importantly, there is a group of people with telomeropathy where you need to think of transplants and also anabolic steroids as well. So I'll stop there. We know it's always never easy evaluating bone marrow failure, because there is a significant overlap between these two conditions. So if you're a scientist, you want to differentiate between these two conditions. But if you're a clinician and if you want to take it pragmatically, you look at the pathophysiology of the diseases and treat it based on it. Thank you.